like Dr. Mathur had recommended, subjecting every gallbladder to a 12-strip examination, economically and clinically, how justified it is, especially when the Western world is now going towards selective biopsy. There's a lot of talk about selective biopsies from the Western world. Of course, there's a huge difference in the incidence of the disease in question. But also, it might be some evidence that says that if the patient has had a laparoscopic conversion to open, it is more chances that this is a malignancy rather than a benign disease. But then, since we want to talk about the preoperative parameters, this is something that I really didn't touch into. If you look at the radiological assessment that is quoted in the literature, we are looking at the stones, the size of the stones, the volume of the stones to the gallbladder volume, the kind of gallbladder wall, and the surrounding structures. So large has been defined with various cutoff values, cutoff of 3 centimeters, 2 centimeters, or 1 centimeter. There is no consensus available on this, what would constitute a large stone, but the studies say that the stones are larger by 1 to 1.2 centimeters in patients who have malignancy. But again, we need to identify which large stone would quantify as a large stone to be associated with gallbladder cancer. The data about this is still ambiguous. Solitary stones, of course, the larger the stone, solid stone, higher chances of it being a cholesterol stone than a pigment stone, higher association with malignancy. And there is some talk about the stone to the gallbladder volume. So this goes all hand in hand. The larger the capacity of the gallbladder that is occupied by the stone, more the inflammation of the gallbladder wall, more chronic inflammatory changes, a higher chance of developing malignancy. I'm just mentioning this because this is what needs to also be assessed on a radiology, whether the patient has an associated gallbladder polyp or a porcelain gallbladder. But when this comes into talk, we are no longer talking about an incidental gallbladder malignancy. When we look at the gallbladder wall thickening, we want to look at whether the thickening is focal thickening or diffuse thickening. Evidence goes to suggest that focal thickening more than 5 mm, which is irregular, there is associated breach in the gallbladder mucosa, the thickening appears inhomogeneous, low in echogenicity, and a central vascularity, has a very high chance of being malignant. A diffuse thickening is more likely to be inflammatory, and thickening in the absence of a fluid collection should be highly suspicious of malignancy. We are coming to GB rats, and that's been just touched upon by Dr. Shraddha, where an Indian consensus has gone ahead and described what would require to be looked at in an ultrasound for suspected gallstone disease. So on the left, this is typically a benign lesion where all layers of the gallbladder wall are seen. The mucosa is seen separately. There is no breach in mucosa. There is no irregularity versus what is there on the right. This is a very important concept for which the radiologists need to be sensitized, because the onus ultimately for identifying gallbladder malignancies preoperatively will be dependent on radiology. GB RADS actually looks into two kind of things. One is the intraluminal changes, how well the gallbladder is distended, and what are the intraluminal contents. That takes me back to that whether it's a single stone, how large the stone is, what is the volume of the stone to the gallbladder, are there any other mass lesions in the gallbladder or not. And then there are mural changes. How is the wall thickened, whether it is symmetrical, asymmetrical, what is the extent of involvement, what is the site of involvement of the wall thickening, is there mural layering. There is a suggestion that if all layers of the gallbladder are seen, it is less likely to be malignancy versus if there is an invasion of the layers, which is more likely to be a malignant change. And how is the interface of the lesion with the liver? GB RADS has gone ahead and described 6 stages, which are equivocal, normal, benign, malignancy being less likely, and malignancy being high likely. This needs to be validated prospectively. This is an expert consensus guideline published in 2022 from a group from India, but this has not been validated. Depending on what your preoperative suspicion is, clinical findings, biochemical findings, and ultrasound findings, it goes on to decide whether we want to do an MRI or CT or any other further imaging or not. So the question to my mind remains is that what would be the parameters to which we decide that after this point in time we require to investigate the patient with more cross-sectional imaging. So we need to have a high index of suspicion which is based on the clinical background. Elderly patients in India, younger cutoff for women, in the Western data, higher cutoff for men, patients who have vague abdominal symptoms, associated weight loss, derangement of liver function tests, which cannot be explained by acute calculus cholecystitis, a proper radiological assessment, which should entail a GB-RADS, followed by any cross-sectional imaging. Thank you.
Thanks, Dr. Siddha. I think we should follow the sequence provided by the organizer. Dr. Deeksha can join us here so that we can have discussion at last. Next speaker is Mr. Dr. Ying-bin Liu from China. He will be delivering his lecture online.
Dear professors and fellows, I would like to give my thanks, very thanks to Professor Kumar for inviting me to make a presentation at this conference. Today, I will share some of my observations and experience on the topic of the proper timing suspected gallbladder cancer in patients with gallstones in clinical practice. Our research and the clinical team based in University Affiliate Hospital in Shanghai, Jiaotong University, China. My team mainly consists of surgeons, oncologists, pathologists, epidemiologists, and statisticians. There have been several interesting controversies and ideas among my faculties about proper approach to screen for gallbladder cancer when treating patients with gallstone. So in my hospital, maybe 1 year, we get gallbladectomy over 300, just 3,000 patients. There have been several interesting controversies and ideas among my faculty. This question began with the surgeons finding that some patients has been diagnosed with gallbladder cancers by biopsy and a simple colectomy for gallstone disease. In summary, except for considering radical regional sex and age patterns, we assume that clinicians may take notice of several indications during the interview with the patients. We'll review the test report and even in the surgery. The importance of an interview patient in outpatient departments is usually ignored because subjective information from patients may not be as accurate and accurate as lab test for image examination. However, systematic interview with special details about known risk factors such as the long-time cause and the family histories and the gallstone history of biliary tract disease, body weight changes, and life habits may help avoid missing the diagnosis of gallbladder cancer. Back in 1980s, Dr. Trevino wrote a report on JAMA, elaborated that the gallstone size may have a positive correlation with the risk of gallbladder cancer. In 1997, a large population-based study was conducted by a former director of Shanghai Cancer Institute before me. After 10 years of follow-up, a report based on the cohort was published. Result of this study indicated that family history of gallbladder cancer significantly increased the risk of gallbladder cancer, especially in those whose first-degree relatives has been diagnosed with gallstones. This conclusion has been well recognized by experts over the world and was cited by 2029 ISMO guideline for biliary tract cancer. The latest available data of a global burden of disease study estimated the significant risk of effect of the 369 disease gallbladder by analyzed disease registry data and found only one risk factor related to the gallbladder cancer and biliary tract cancer, which is high BMI. Previous research about high BMI as a risk factor analyzed GBC data and found that high BMI attributes more to gallbladder cancer in females than males. Image examination as a favorite test of surgeons, for it can intuitively guide diagnosis and treatment when a patient complains about abdominal pain or discomfort occurs. According to the experience of my faculty, ultrasound, CT scan, and MR are the most popular and efficient approach to different gallbladder cancer from simple disease. Description in image examination reports like the center wall and atrophy, neuroplasm on the structural anatomy of a gallbladder usually alert clinical for potential risk of the malignant. Last year, American College of Radiology reported that and the data system has published a consistent named GB readers to guide the categorization of a gallbladder with a gradually increased risk of malignancy. In fact, our research team has been working on building the prediction model and the risk stratification system fitting the different characteristics of different locations. Chinese research group of gallbladder cancer, my leader, I am the leader, consists of a dozen of surgical centers in China and has gathered and structuralized epidemiological, clinical, and pathology information of more than 10,000 gallbladder cancer patients. We believe that looking at the cohort and well structured real-world data is the foundation for further population-based research, and more accurate precise diagnosis pattern will be built with the improvement of the population-targeted research. There are some photos of my research team. They are all dedicated specialists working on basic kind of clinical research of pancreas biliary disease. We welcome experts and specialist fellows over the world to visit our faculty in Shanghai and share their experience and views, as well as academic cooperation. Finally, I give my thanks, special thanks to the Coopers, Professor Cooper, giving me a chance. But the visa reason I can't go to the India. 就是我怎么感到非常遗憾。
Thanks, Professor Liu, for your
Right.
excellent talk. I request you to wait for the question answer session to be online with us. Next speaker will be Dr. Osman from Turkey. He will also deliver his talk online. Please play the next talk.
ऑन करना स्विच करना ऑडियंस
Good morning. Thank you for this kind invitation and introduction. I will give my comments on this topic in 2 minutes. When to suspect gallbladder cancer is a difficult question. Actually, there are 2 reasons for this difficulty. First one is prevalence of gallstone disease is very high. It's like a forest. About 15 to 20% of the population has gallstone disease, and this is even higher in females. And the problem is the rarity of gallbladder cancer. Gallbladder cancer accounts less than 1% of all cancers. So the suspect is big, but target is small. So it's really a difficult problem to predict gallbladder cancer in patients with disease. On the other hand, incidental gallbladder malignancy is reported in less than 1% of all routine cholecystectomies for benign disease. Gallbladder cancer is rare, and it's also rare in cholecystectomies performed for gallstone. Besides this, there are well-defined risk factors, and basically these rely on history and radiologic findings. Old age is a risk factor, especially patients older than 65 years old, and ultrasonography findings, including thickening of the gallbladder wall, bile duct dilatation, and presence of lymphadenopathies may predict gallbladder cancer. Unfortunately, these risk factors are not always reliable. Besides these well-known risk factors, there are some other risk factors. We know some studies showing that if gallstone is larger than 3 centimeters in diameter, the risk of cancer is increased. Again, the presence of gallstone and large polyp, usually larger than 1 centimeter, may be a risk factor. And in addition to these, general risk factors for gallbladder cancer, like family history, obesity, ethnicity, may predict the cancer risk. In my experience, usually I think that asymmetric gallbladder wall biochemistry tests in these patients before taking these patients to surgery. I would like to thank you all for giving me this opportunity, and I'm glad that I was with you last year in Jaipur, but this year I couldn't make it. Hopefully we'll meet in person in the future Jaipur surgery meetings. Thank you again.
Thanks, Professor, for your nice talk. I'll request Professor Liu and Professor Osman to stay with us online for the question answer session. I also request Dr. Deeksha to join us on the dais for the question answer. Now house is open for the discussion for the topic when to suspect gallbladder cancer in patient with gallstone disease. That is, what is the definition of a suspected gallbladder cancer in patient with gallstone disease? Yes, sir.
Hi, thank you for the nice presentations, enjoyed it. Sridhar here from Singapore. So I think we need to have some clarity on these definitions of when to suspect, because we don't bat an eyelid when there is a thickened gallbladder on ultrasound report. And most of them are chronic cholecystitis. Half of them are done by the residents. There was a lot of talk about opening the gallbladder and looking at it. Are the eyes trained to look at it? Somebody who is certified to do a gallbladder and exited their exams are competent. So we need to be very practical. Now even the definitions that we put when we suspect gallbladder cancer under these circumstances, let's say they have a 99% sensitivity and a 99% specificity. But if the prevalence is 1% in the population, that means it has only 50% accuracy. So basically, the population incidence will determine how accurate the test is. So if we are going to define something, it has to be defined across the population and not just specific to certain high-risk incidence areas. So that's my difficulty. So where do we draw the line? So best to have a sort of a Delphi consensus, because once we have guidelines, then you are, if you miss a gallbladder cancer, you will be liable if you don't follow those things. But otherwise, you know, thick wall gallbladder in a high prevalence area, yeah, index of suspicion is high. In a low prevalence of area, index of suspicion will be low.
Dr. Deeksha, you would like to comment?
So that's a very valid point. But even if we are identifying those 50% patients, I think we are on the nail. The other is, of course, I think what we need is a Delphi consensus in which we decide that based on the available data and literature, these are the pointers where we start suspecting malignancy and start doing additional tests. So actually, I wanted to ask the House 4 questions as to what should be the age cutoff when we should start suspecting malignancy. Do we, for the Indian scenario, do we want to keep it at 50, 55, 60 or 65? Because all the data comes for 65 as a cutoff. That's also what Professor here on his comments mentioned.
Yes, sir.
Next, I'm Kishi from Japan. You mentioned that, I think the diagnosis of gallbladder cancer in gallbladder cancer is still a very difficult problem. And as you mentioned, the large system, the focal irregularity or thickening of the gallbladder wall could be one of the major or important findings. But I suspect the sensitivity or specificity to detect gallbladder cancer is still low. But in such cases, if you find the cases with focal thickening or irregularity in gallbladder cancer, you mentioned CT or MRI could be recommended. But in such cases, if the patient is especially with symptomatic with acute cholecystitis, do you recommend simple index cholecystectomy or schedule postpone the operation for the further examination for the assessment of cancer?
No, what I believe is if there is some thickening in the gallbladder, which is asymmetrical, focal, in a patient who has large stones, which raises suspicion for malignancy, cross-sectional imaging may be recommended in the form of a contrast-enhanced MRI or a contrast-enhanced CT scan. And the surgery should include a frozen section followed by, if we find evidence of malignancy, to proceed to a radical cholecystectomy.
Dr. Deeksha, what should be the suspected gallbladder cancer? What should be the definition of a suspected gallbladder cancer in patient with symptomatic patient with gallstone disease comes to our OPD?
So in a patient who's elderly, for Indian scenario, I would say that 65 is a little on a higher cutoff. For our scenario, we might want to decide a little lower cutoff. Patient for whom the symptoms do not fit into a typical gallstone disease. Either it's an incidentally diagnosed large stones with wall thickening, there are vague abdominal symptoms, associated weight loss, there is derangement of liver function tests which do not get explained as acute cholecystitis, and the ultrasound findings are not of a plain simple gallbladder. I think we should evaluate further for malignancy.
Professor Liu, what should be a suspected gallbladder cancer? When will you suspect gallbladder cancer? What should be the definition? Professor Liu, please.
Yes. Yeah. That's also sorry, pardon?
What are the findings, clinical or radiological, on ultrasound when will to suspect a patient with gallbladder cancer? The patient may harbor gallbladder cancer. When will you suspect? What is the criteria for that? Professor Osman, you can also
So we can't follow you clearly because of the bad internet. So is your question about which symptoms should be for the gallbladder cancer for the surgery or something like that? Yes.
or what should be the criteria for to suspect gallbladder cancer, maybe on ultrasound or clinical?
Clinical what?
Yeah.
Sorry, I can't follow your question.
I think you can place question, but what should be the criteria for Sadiq sir to suspect a patient with gallbladder cancer? Yes, sir. Should be age only age in isolation should be a criteria for it. Should be in association with other factors should be a criteria for the to suspect gallbladder cancer.
Could you please type in the question in the?
Just I would like to make one comment. As we have listened to the talks, BMI is a predictor, age is a predictor, size of the stone is a predictor, in biochemical alkaline phosphatase is a predictor, previous study CA 19.9 is a predictor. Can't the House or make a consensus and make a scoring system based on the clinical, radiological, the GB rad imaging and the biochemical parameter to say that when to suspect a gallbladder cancer in a patient with gallstone disease? A patient, young female with a large stone is having more risk rather than a patient with even 55 years of age and a small calculi I feel is at lesser risk. Can't we assign score to each of the risk factor and then devise the when to suspect a gallbladder cancer in a patient with gallstone disease?
So you're very right that there is evidence that goes and says that patients with comorbidities, obese, hypertriglyceridemia, elevated CA99, but when you look at the data or the statistics, the odds ratio or the hazard ratio are not very high. They have not even crossed 2, or they are in the early parts of, between 1.3 and 1.6 or 7. Do we want to investigate every patient with a CT scan or an MRI? If that is there, is the question. Also, we need to differentiate the data that is coming from the West versus what's coming from India. We know from our epidemiological studies that gallbladder malignancy is seen at a younger age in women. We keep a cutoff of 65 for investigating a potential malignancy. We are going to miss out a big chunk of incidental or suspected gallbladder malignancies. I think it has to be, a lot of it requires uniformity of imaging, a proper reporting, and then identifying which factors can have the maximum prediction. Radiology will likely play the most important part. If an asymmetrical focal thickening of the gallbladder is documented, it might be prudent to say that it mandates further investigation irrespective of the age or the size of the stones.
Dr. Deeksha, idea of this talk is to define patient with suspected gallbladder cancer to avoid, to reduce incidence of missed gallbladder cancer by providing them adequate imaging and adequate treatment, appropriate treatment, and to avoid over treatment and under treatment for the patient. For that, we have to make some guidelines. In my opinion, as Dr. Kapoor said, any gallbladder on ultrasound having more than 3 mm of thickness, may be focal or circumferential, should be considered as a first suspicion for the gallbladder cancer, and depending on the clinical and other age factor or biochemical factor, it should be further evaluated. Suppose if a patient has got raised bilirubin, acute cholestatis, they should LFTD range, raised bilirubin, raised alpha, they should go for MRI for further diagnosis, and patient with acute symptoms and signs of acute cholestasis should go for CT scan first. Patient with suspected Xantho should be evaluated according to that, maybe CT or MR or endoscopic ultrasound or further imaging to decide the treatment plan.
Yes, sir, I agree. Sir, Dr. Liu or Dr. Osman, hi, can you hear me? Good morning.
Good morning. Yes, I can clearly hear you.
Sir, would you like to make some comments?
Yes, please. Thank you very much for your nice presentation and nice review. Actually, in my country, in Turkey, the prevalence of gallbladder cancer is not very high. So, regarding ethnicity, the Turkey is not a common part of the world regarding gallbladder cancer. In my clinical experience, number one finding suggesting gallbladder cancer is asymmetrical gallbladder wall thickening. You know, in many patients we see gallbladder thickening for long-standing chronic or acute cholecystitis effects, but these are for entire gallbladder wall. In cases with gallbladder cancers, according to my experience, this thickening is to a certain part of the gallbladder wall, and it's asymmetrical, not circumferential. And the second important finding in my practice is atypical presentation. And the most important finding is persistent pain. In gallstone disease, the pain is usually colicky, it comes and goes, but in cancer it's persistent. So if I see a patient with persistent pain and asymmetrical gallbladder wall thickening, I always order an MRI scan, not CT. In my personal experience, if sonography findings are and clinical findings are in correlation with cancer, the next step should be MRI, not CT. MRI seems superior to CT, and in MRI, the most prominent finding is nodular thickening without layering. If the layering anatomy of the gallbladder is disrupted, it's most likely a cancer. So we go in a stepwise fashion, and also agree with all the speakers that drawing a line is very difficult. And I think we have to work on this field for many years for clear definitions. But for now, we have to rely on sonography and MRI according to my experience. Again, thank you all for the kind invitation.
Thank you, sir. Thank you for chipping in.
Yes, sir.
Actually, what we are trying to do is we are trying to put suspected gallbladder in a single basket. Suspected gallbladder should be clearly categorized as clinically suspected, radiologically suspected, suspected at the time of laparotomy or laparoscopy,
Yes,
or suspected after opening the gallbladder. And all four scenarios need to be discussed and handled differently. There is no single answer to it. And
what should be clinical criteria, sir?
clinical criteria she has very wonderfully outlined. The moment you have an older lady, the moment the patient is a female gender, there is a pain, persistent pain, If there is a jaundice, there is a weight loss, you should consider it as clinically suspectable. And if your ultrasound findings, the first investigation obviously is an ultrasound. And if your ultrasound finding does not correlate with your clinical history, you should proceed with further investigations.
Okay, fair
So-
enough. Sir, sorry, sir.
So I have two comments. One is, your point about having a scoring system. So the Dutch have made a scoring system of various clinical parameters to suspect whether they should send the specimen for histology or not,
Yes, sir.
with a high sort of incidence of cancer in that. And we could have a similar kind of scoring system because our parameters will be very different from what they have taken. But I think that may be one of the important steps to collate all the high risk factors and at least to say that in these more detailed evaluation should be performed. And that we have enough data so as to collate that and come out with a scoring system. The second part is about the thick-walled gallbladder, what Dr. Nag you mentioned. Now, long back, if Dr. Kapoor would remember, we did a study at SGPGI
Yes, sir.
of thick-walled GB, which were all examined by a CT scan,
Yes, sir.
right, uniform thick wall. And 3% had gallbladder cancer in the thick-walled gallbladder. But interestingly, none of those 3 were picked up on CT scan.
Yes.
So, to say that uniform thick wall, and this is in Lucknow, so a high incidence belt. So to say that all thick wall GB scans should be, gallbladders should be viewed with suspicion and evaluated further would be a much higher burden of investigation to all of them. So these points that focal thickening certainly uniformly comes as a important point. But I still feel that this group can come out with a scoring system which would collate all the data. Thank you.
Okay, sir. Sir, I think points are well taken. House agrees to have clinical features to suspect gallbladder cancer. Then ultrasonological features should be defined. To then further imaging should also be defined. I think this topic needs further discussion to frame the final guidelines.